Welcome to the deep dive. Today, we're getting into something really critical in healthcare, quality improvement, specifically within the intensive care unit, the ICU.
Right, the ICU. This is where patients are at their most vulnerable, so driving up the quality of care, making it safer, more effective, it's just essential.
Absolutely. So in this deep dive, we want to break down what QI actually looks like in the ICU, why it's so crucial there.
And maybe highlight some practical ways it's done, some real successes too. So whether you're maybe prepping for a meeting or just catching up on healthcare.
Or even just curious about how hospitals get better. This should be really useful for you.
Yeah. And to do this, we've pulled together insights from quite a few places.
We have. We're looking at big international players like Joint Commission International, JCI.
And NABH for the Indian context, the National Accreditation Board for Hospitals and Healthcare Providers.
Plus the International Society for Quality in Healthcare, ISQA. And we've also got some practical insights from Streamlining Consultancy.
And materials really focus specifically on ICU quality improvement itself. So a good mix.
Should give us a pretty rounded view, hopefully.
Our mission today really is just to pull out the key stuff on ICU QI, make it understandable.
And pinpoint those main takeaways that you can really hold on to.
Exactly.
Okay, so let's kick things off by looking at the landscape of healthcare quality accreditation. JCI comes up immediately. Big global name. What's the main thing to grasp about them?
Well, JCI, think of them as setting a global benchmark. They operate in, over 70 countries, accrediting more than 1,000 programs.
Wow.
Their whole mission is about enabling and affirming the highest standards, for quality and patient safety everywhere. So getting JCI accreditation, it's a big deal internationally.
And that involves some pretty tough standards, I imagine. What are those standards for?
Exactly. They develop these rigorous international standards. That's the foundation for how they evaluate hospitals and clinics. It's all designed to help organizations measure themselves, assess where they are, and then, crucially, improve. They also have specific international patient safety goals targeting those high-risk spots.
Makes sense. So that's the global picture. Now, NABH, you mentioned, that's more focused on India.
That's right. NABH is part of the Quality Council of India. Their job is setting up accreditation programs specifically for healthcare within India.
So establishing the benchmarks there.
Precisely. Setting benchmarks for the Indian health industry, making sure it meets patient needs.
Then there's ISQA. How do they fit into this quality improvement world?
ISQA is more about connecting people and promoting QI globally. They're a nonprofit, member-based group, been around over 30 years.
Okay.
They do a lot through education, sharing knowledge, external evaluations, supporting health systems. They have a huge network, also across 70-plus countries, so they're really about fostering that global community of practice.
Interesting how they all play slightly different roles. And Streamlining Consultancy, where do they come in? Sounds more hands-on.
Yeah, they're about the practical application. They actually help hospitals implement quality management systems, navigate getting NABH accreditation, for instance.
Okay, so they help translate those big standards into action on the ground.
Exactly. Shows how these frameworks actually get used day-to-day in hospitals.
So taken together, these organizations kind of build the scaffolding for quality improvement, especially in demanding places like the ICU. All right, we've set the stage. Let's zoom into the ICU itself. What does quality really mean in that specific high-pressure environment?
In the ICU, quality fundamentally boils down to care that's timely, evidence-based, and really focused on the patient.
Okay.
And crucially, it's about minimizing harm, maximizing good outcomes, and using resources wisely.
That seems pretty comprehensive. Does it break down into specific areas?
Oh, absolutely. It covers several domains. Clinically, it's about effective treatments, avoiding complications. Operationally, it's efficiency, getting patients the care they need promptly. Ethically, it's things like respecting patient wishes, clear communication, especially around difficult decisions like end-of-life care. That's huge for quality.
And you mentioned an emotional aspect, too.
Yes, definitely. Managing pain effectively, ensuring families feel supported and informed, that's absolutely part of high-quality ICU care.
Got it. Now, ICUs already have guidelines, protocols. They seem pretty structured. So why is a separate formal QI approach still so necessary? Isn't quality sort of built in?
That's a really good question. And you're right, they do have protocols, but there can be a surprising amount of variation in how consistently those protocols are actually applied unit to unit.
Okay. Consistency is key.
Exactly. Think about how strictly best practices are followed, or how well the team communicates under pressure, or even basic stuff like infection control. Plus, the ICU is inherently high risk. Small slip-ups can have massive consequences for these patients.
So QI brings that layer of reliability, of making sure the good practices happen every single time.
Precisely. Structured QI helps ensure everyone consistently uses things like CARE, bundles those sets of evidence-based steps for, say, preventing ventilator pneumonia or central line infections.
Right.
And it also creates a system for learning when things don't go right, using data to make decisions, building a culture where staff feel safe pointing out risks. It's about making the system safer overall. You can have amazing tech, but without strong QI, basic care can falter.
Okay, that really clarifies the why. So let's get practical. What are the key strategies, the actual interventions ICUs use for QI day to day?
Well, a huge focus is always on patient safety, reducing errors. That means really embedding evidence-based clinical guidelines and protocols into daily work.
Making sure everyone follows the best practice.
Yes. And another major area is cutting down on hospital-acquired infections, nosocomial infections. That comes down to things like rigorous hand hygiene, proper care of lines and catheters.
Simple but vital stuff.
Absolutely.
Yeah.
And medication safety is another big one. Using systems to double-check orders, maybe using technology like barcode scanning to prevent mistakes.
Beyond those direct actions, what about the people? Staff training must be critical.
Foundational. You need ongoing education for everyone. Doctors, nurses, therapists, on the latest practices, new technologies, advanced techniques.
Keeping everyone up to speed.
Right. And just as important is fostering that interdisciplinary collaboration. The ICU relies on teamwork. So ensuring smooth communication and coordination between all the different specialists is key to safe, seamless care.
Okay, we've got the standards, the interventions, the people. How do ICUs actually know if they're improving? What are they measuring?
Data. Data collection and monitoring are the absolute backbone. ICUs track key performance indicators, KPIs. These are specific metrics reflecting performance.
Like what, for example?
Oh, things like infection rates VAP for ventilator pneumonia, CLAB-SI for central line infections, CIU-TI for urinary tract infections. Also, ICU mortality rates, unplanned extubations.
When tubes come out unexpectedly.
Exactly. Or reintubation rates. Also length of stay and readmission rates back to the ICU. If you had to pick the top ones for a snapshot, probably mortality, infection rates, and length of stay, they really show outcomes and efficiency.
That sounds like a lot to track. How do they manage it all?
Many use clinical quality registries, CQRs. These databases pull data from multiple ICUs.
Ah, so they can compare. Benchmarking.
Precisely. See how you stack up against similar units, identify who's doing things really well? But the key is not just collecting data, it's using it. Regularly reviewing it, looking for trends, spotting areas needing attention.
And I guess they often visualize this.
Yeah, ICU dashboards are common. Quick visual overview of performance at a glance.
So using that data, what kinds of ongoing improvement projects do ICUs typically run?
Well, the data points you towards specific projects. If reintubation rates creep up, you launch a project to figure out why and fix it.
Makes sense. Targeted efforts.
Exactly. And there's a growing focus now on really involving patients and families in care decisions, making it truly patient-centered. And crucially, these aren't just one-off projects. You have to keep measuring, monitoring progress, tweaking things as you go to make sure improvements stick.
And technology. We hear so much about digital health. How's that impacting ICU QI?
It's becoming huge. Electronic health records, EHRs, make documentation easier, improve communication, give instant access to patient info that helps coordination and cuts errors.
Less paper, faster access.
Right. And advanced analytics can now sift through all that data to spot complex patterns, maybe even predict risks before they happen, or help tailor treatments.
Personalizing care through data.
Potentially, yes. And technology is also used to improve the patient experience itself. Better communication tools, comfort measures, ways for families to connect.
You've laid out some really solid strategies. Can you give us some concrete examples? Real-world QI projects that actually move the needle. It helps to see it in action.
Sure. A classic, really impactful one is the ventilator bundle. Those steps to prevent VAP.
Right. Ventilator-associated pneumonia.
Yes. By training staff consistently, using EHR prompts for things like elevating the head of the bed, preventing ulcers, giving sedation breaks. Some ICUs have seen like a 40% drop in VAP rates in just 6 months.
Wow, 40%. That shows the power of just doing the basics consistently.
Absolutely. It's about reliable implementation.
What's another good example?
Sepsis protocols. Early recognition is key with sepsis, so empowering nurses, maybe in the ER, to spot early signs and trigger alerts quickly.
Cutting down that time to get antibiotics in.
Dramatically.
Yeah.
And that saves lives. Every minute counts with sepsis. It highlights how QI can improve time-sensitive care.
And what about teamwork? You mentioned collaboration earlier. Any QI examples there?
Yes, multidisciplinary rounds using a daily goals checklist. This brings the whole team, intensivist, nurse, pharmacist, dietitian together.
Everyone on the same page.
Exactly. They review each patient, set clear goals for the day using a checklist. It boosts clarity, communication, and stops things falling through the cracks.
Makes sense. We also hear about issues like delirium in the ICU, patient comfort. Are there projects focused there?
Definitely. Delirium prevention is a major focus. Using standard tools like the CAM ICU to screen regularly.
Okay.
And then intervening with things like early mobilization, getting patients moving sooner, using sedation carefully, keeping a normal day-night rhythm. It really helps.
And that leads to better outcomes.
Yeah, reduced sedative use, shorter ICU stays. It's often wrapped up in the ABCDEF bundle.
Ah, yes, I've heard of that. Assess pain.
Both awakening and breathing trials, choice of sedation, delirium monitoring and management, early mobility, and family engagement. A really comprehensive approach.
It's great to see these structured methods. Do we have any specific hospital case studies that show the impact?
Yes, a few good ones. AMS Delhi, for example, focused hard on their CLABSI bundle preventing central line infections.
Okay.
Through training and really pushing implementation, they got compliance up from around 40% to 95% in 6 months.
That's a massive jump.
It is.
Yeah.
And their actual CLABSI rate plummeted from 5.2 infections per 1,000 line days down to 0.8. Just incredible patient safety improvement.
That's a tangible result. Any others?
Intermountain Healthcare used lean methods in their ICUs, standardizing rounds, care bundles.
What happened there?
They cut the average length of stay by 25% and saved an estimated $1.2 million a year. Shows the efficiency gains, too.
Wow. Efficiency and quality.
And one more, Singapore General Hospital focused on early mobilization, getting even ventilated patients out of bed more.
Simple idea, but...
Effective. It led to less delirium and shorter overall hospital stays. These examples really drive home the real-world benefits of focused QI.
These stories are definitely inspiring, but I imagine it's not always smooth sailing implementing these changes in such a high-pressure place like an ICU. What typically gets in the way? What are the barriers?
You're spot on. It can be tough. A big one is often just resistance to change, that whole "but we've always done it this way" mentality.
Yeah, that's hard to shift.
Very. Then there's the sheer workload. ICU staff are incredibly busy, under pressure. QI can sometimes feel like another thing to do on top of everything else.
Like an extra burden.
Right. Poor data systems don't help either. If tracking data is all manual, really time-consuming audits, it becomes a barrier, not a tool.
Yeah, exhausting.
And finally, lack of real leadership support. If management doesn't carve out protected time or resources for QI work, it's hard for it to take root.
Okay, those are significant hurdles. So how do ICUs get past them? What strategies work to actually build that quality culture?
Often the best way is to start small. Pick one metric, one motivated team, get a win.
Build momentum.
Exactly. Celebrate successes, even small ones. That helps build buy-in. Using technology smartly helps too, like EHR checklists, real-time dashboards that can ease the data burden.
Make it easier to do the right thing.
Yes, and maybe the most important thing, involve everyone, especially the frontline nurses and residents. They see the issues day to day. They have great ideas.
Make it everyone's job.
That's the key. QI works best when it's seen as everyone's responsibility, not just some committee's project.
We've talked a lot about the internal workings. How does external accreditation, like from JCI or NABH we mentioned earlier, fit in? Does that help drive quality?
It absolutely does. Accreditation provides a solid framework.
Right.
Those JCI standards, for instance, they form the basis for a whole evaluation process.
Right.
It forces organizations to systematically measure themselves, assess their performance, and find ways to improve across the board. An interesting side effect.
Yeah.
Many places find going through accreditation actually helps build teamwork, improves communication between departments.
Kind of a shared goal that brings people together.
Exactly.
And I guess achieving it has benefits beyond just the internal improvement.
Oh, definitely. It could be a competitive advantage for a hospital. And it really boosts community confidence, knowing the hospital meets high standards for quality and safety.
And places like Supreme Medic help hospitals get there.
Right. They offer practical help for meeting those accreditation standards, like for NABH. Shows the practical steps involved.
Okay, looking ahead now. What's coming next in ICU quality improvement? Any emerging trends or innovations we should be watching?
It's a really dynamic field. We're seeing AI starting to play a role, things like AI-powered early warning systems.
Predicting problems sooner.
Potentially, yeah. Catching deterioration before staff might even see it. Tele-ICU is growing too, allowing remote quality audits, spreading expertise.
Especially helpful for smaller or rural hospitals.
Could be, yes. Simulation training is getting more sophisticated too, for practicing critical skills safely.
Right.
And there's a bigger push to use patient and family feedback more systematically, not just for satisfaction scores, but to really understand and improve the human side of care.
That seems important.
And finally, a growing recognition that you can't have high-quality patient care without looking after the mental health and well-being of the ICU staff themselves. That's becoming a key part of the quality equation.
That makes total sense. This has been incredibly insightful, really unpacking ICU QI. To wrap things up, what are the absolute key takeaways you want our listeners to walk away with?
I think the main thing is that ICU quality improvement isn't a project. It's a continuous, essential effort.
Yeah.
It's all about patient safety, effective care, efficiency, and building a culture where learning and improving are constant.
Right.
It needs data, teamwork, commitment to best practices, and increasingly smart use of technology. And those accreditation bodies, JCI and ABH, they provide really valuable frameworks to guide it all.
And a final thought for you, the listener. As you think about our conversation, maybe consider how these principles of continuous improvement using data, collaborating, striving for excellence might apply beyond the ICU, maybe in other complex, high-stakes areas you encounter in your work or life. It really comes down to that commitment to getting better. Thanks for joining us for this deep dive.